get started once I see the little recording things pop up. How about that?
It's on.
Is it? All right. Great. Well, good morning, everyone. Happy Wednesday. Really delighted to see so many of you here. And I know some of you are listening from the car based on the chat. So we really want to thank all of you for being here and for being here so early and doing this, not only as part of your day, but perhaps before your days even started. For those of you who I haven't met, my name is Kathleen Kieran. I am, along with Dr. Peter Asante, one of the Equity co-chairs for our work group, and also trustee for the Washington chapter of the AAP. And my other job, I am a pediatric urologist at Seattle Children's Hospital, and I work in both Seattle and the Tri-Cities. So this is the very first installment of our Equitable Care webinar series. And today we have two great guest speakers who will be talking about educating providers on equity and racism. I didn't go to the next slide. That's great. Thank you. So just by brief agenda setting here, just to kind of know what you're getting into for the next hour, I'll give you a little bit of background on the toolkit that inspired this webinar. I'll talk a little bit about what we're hoping to accomplish with today's webinar and with each of the different buckets within the toolkit. And then Dr. Asante will move forward to introduce our speakers. So I think we're all aware that 2020 was definitely a year where there was much needed national reckoning about basically how we were treating other people. Yeah, I think anti-racism came to the fore and the need for equity, diversity, and inclusion certainly came up. And the Washington chapter of the AAP has always been committed to those efforts. But we felt that last year, our efforts really needed to be more actionable, and certainly as sponsors and promoters of health for all children within the state, we needed to be able to provide information and provide skills for other people that were looking to improve themselves in that way. And so this begat the Equity Work Group. What we have here is the Equity Work Group co-chairs, me and Peter. And then you can see that we have several different people in each of the what we call buckets, but provider education, physical space, safe and effective care, and then promoting equity, diversity, and inclusion in healthcare. And this was actually a really elite group. They're diverse in so many different ways, both demographically, geographically, experience. They applied, they had to tell us why they wanted to do this. So these are people who were really committed to doing the work. And our hope was that by bringing this group together, even with these somewhat artificial demarcations, that we would be able to make a very robust toolkit that would serve as a resource for not only pediatricians, but other healthcare providers and anyone who comes in contact with the patients in any capacity across Washington state. And so we could be a resource for children, for those who care for children, those who care for adolescents, and anyone in the office. So the first bucket is provider education, general education, and that's what our webinar will be on today. Our hope is that we'll be able to help providers understand how racism affects the overall, including mental and physical health of all children, adolescents, and those who care for them. We're going to provide definitions to help expand your vocabulary of relevant terms and concepts. And of course, we're going to encourage each of us, myself included, to look inside ourselves and look inside our practice and what we do on a daily basis, to look for blind spots and look for both implicit and explicit biases that may adversely affect the care that we're delivering. So with this, I'm going to turn it over to Dr. Asante, and I hope you enjoy the webinar.
Good morning, everyone. I'm Dr. Peter Asante. I am a general pediatrician at Yakima Pediatrics in Yakima, Washington, as well as medical director of the Teen Health Clinic here at Yakima Pediatrics and chair of pediatrics at Virginia Mason Memorial, or Yakima Memorial, here in Yakima. Kathleen, thanks for a great introduction. And so at this point, it's my job to talk a little bit about sort of our webinar series schedule. I did want to let people know that we have a toolkit that will be published in the next week on our website. And over the course of our talk, I will send the link to that so that people have access to it. And when it goes live, there will be an email that goes to all members, but also just expect it within the next week. And then this is the calendar of webinars that are coming up to really address interactively the buckets that we were just talking about earlier. On Wednesday, June 30th, we will talk about how to make physical spaces more affirming and inclusive for our patients and families. On Wednesday, September 29th, we will talk about ways to provide safe and effective quality care and ways that we sort of expand how we think about our patients and make sure that we do that in a manner that really sort of dovetails a lot of the discussion that we're actually going to have today about educating our colleagues and ourselves about racism in medicine. And then the last webinar will be December 8th, which is promoting diversity, equity, and inclusion within our healthcare institutions. Really a very high level view at the end of our year-long exploration of equity and racism in medicine. Next slide. And so with that, I don't like to talk that much at 7 a.m. because I'm not awake. And so I'm really glad that 2 other people get to do the talking for the next hour. I would like to welcome our presenters this morning. First is Dr. Roberto Montenegro, who is a child and adolescent psychiatrist and assistant professor at Seattle Children's Hospital and the UW Department of Psychiatry, as well as adjunct assistant professor in pediatrics. He can tell you a little bit more about himself, but he does a lot, including serving as director of the mental health services at Equitable Children's Center and specializes in cross-cultural psychiatry, mental health, and hard of hearing, and mental health for incarcerated youth. And then our main topic speaker this morning, I'm very excited to introduce Dr. Shruti Prasardi. She is a first-year resident at Seattle Children's Hospital and University of Washington. She is part of the REACH pathway, which is an advocacy pathway that talks much about global and community health within the course of the residency through a longitudinal curriculum. And that is between Seattle Children's Hospital and the Community and Regional Hospital of Kisii, Kenya. She has previously worked on projects to improve community awareness of malaria in rural South Africa, to characterize the barriers of maternal and childhood healthcare for stateless migrant families in Malaysia, and to characterize the incidence of zoonosis in rural northern Tanzania. And so with that, I will let them take it over. I just want to let people know that the presentation is about 30 to 40 minutes long. And then after that, if everybody wouldn't mind holding their questions, we will take them after the presentation. All right, it's all yours, you guys.
Thank you for that lovely introduction. Good morning, everyone. My name is Shruti Prasardi. I'm a pediatrics resident at Seattle Children's and the University of Washington. Thank you for joining me today as I explore how we as participants in and providers of healthcare can address racism and health inequities in the clinical setting. While I present, my faculty advisor, Dr. Roberto Montenegro, will be helping to manage the chat and share responses from all of you in the audience. I'm joining you today from Seattle, Washington, so I'd like to acknowledge the land that I stand on, the traditional land of the Duwamish people, the first people of Seattle, and would like to express my gratitude for this land itself and honor the ancient heritage of the Duwamish people who continue to be with us today. I also want to acknowledge that this statement in and of itself will not improve the Duwamish people's material or political condition, and I hold myself accountable to take actions that will contribute to the well-being of the Duwamish people. Today, as you all virtually join me from all over Washington state, I encourage you to take a moment to acknowledge by name the first people who inhabited the area you live and practice in. I also encourage you to find ways to directly contribute to the present day descendants of those first people. I have 4 broad goals today. First, to review, learn, and understand the concepts and language used in health equity, such as implicit bias and structural racism. Having a shared understanding of these terms will help us to build common ground as we approach challenges in health equity together. Second, to identify implicit bias and structural racism in clinical scenarios specific to pediatrics. Third, to develop strategies to combat implicit bias and structural racism in daily patient care as individuals. And finally, to practice these strategies in real clinical scenarios. Before we delve further, let's set a few ground rules to ensure a respectful and positive learning environment. First, we operate with the shared view that all participants should participate freely but respectfully. Throughout the presentation, you will see these chat bubbles appear. When you see them, we're asking you to take a moment to think about the question and please share in the chat. We're all committed to learning, not debating. There will be no blaming and no shaming. Embrace discomfort. Health equity work, by definition, requires confronting our own prejudices, which is difficult but necessary to move forward. We must give ourselves grace for our mistakes and avoid becoming defensive. We assume that all providers in the care of these patients were acting in what they felt to be the patient's best interest. Details of these cases have been altered to protect patient confidentiality. Now let's explore some important definitions and concepts that will lay the groundwork for the rest of the session. Race is a primary driver of bias. However, it's certainly not the only driver of bias. Many other social aspects include gender, sexuality, religion, ability and disability, and language, and also drive bias and health inequities. Because race is one of the foundational drivers of health inequity, let's discuss race and its relevance to pediatrics. The idea of race assumes that simple external differences rooted in biology are linked to other, more complex internal differences. This belief is based on the incorrect idea that race is biologically real. In reality, race is a sociopolitical classification system that assigns individuals and groups based on arbitrary traits to categories that are ranked and hierarchical. Race is an idea that we ascribe to biology that has been used to justify social inequality as natural. Race has no genetic basis. There is clear evidence that there is as much or more genetic diversity within a racial group as there is between racial groups. Racism, however, is very real. It's a system of power that restructures as an inequitable distribution of opportunity, benefit, resources, or capacity, and assigns value based on social interpretation of how one looks. Racism unfairly disadvantages some individuals and communities and unfairly advantages other individuals and communities. Inequality produced by discrimination harms everyone in society, even groups who in some ways benefit from racism. The concept of race is an artifact of European colonization used to create hierarchy and justify the enslavement of non-European peoples as a part of an emerging global economy. Over the centuries, religious, philosophical, political, class-based, and biological justifications have been used for racial oppression. The concept of race was perpetuated throughout US history to continue to protect the dominant power and privilege held by white people in the past, at the expense of the quote-unquote other group or racial minorities. This power dynamic is one that persists to this day. But how is racism relevant to the practice of pediatrics? Research shows that physicians unwittingly perpetuate healthcare disparities by making clinical decisions based on implicit racial stereotypes. For example, Black children are frequently undertreated for pain compared to white children. Racial bias has also been linked to unconscious physician preference for white patients and poor ratings of interpersonal care in interactions with patients of color. Minority patients receive fewer recommended treatments for illnesses ranging from cancer to childhood trauma and ADHD, leading to persistent racial gaps in healthcare outcomes. Previously healthy Black children experience higher post-operative complications, adverse events, and mortality compared to previously healthy white children. In a study of patients with acute gastroenteritis at a large urban academic pediatric center over 7 years, researchers found that after adjusting for age, gender, language, insurance, and triage acuity, patients who identified as non-Hispanic, Black, Hispanic, and other race patients were significantly less likely to receive IV fluids and be admitted to the hospital compared to white patients. It is important to understand the different forms of racism that perpetuate discrimination and are prevalent in our medical institutions. Racism, as a system of power and prejudice, operates on different levels. Structural racism is is racial bias across institutions and society over time. It is the cumulative and compounded effect of multiple forms of discrimination that work together to perpetuate racial inequity, which ultimately provides white individuals with advantages while producing negative outcomes for BIPOC. This ultimately contributes to interpersonal discrimination and bias, societal norms, cultural representations, ideologies, institutional practices, and public policies, both past and present. All of these work together to perpetuate racial inequities and lead to disparities in health, including increased medical errors and mortality. The purpose of this talk is not to explore how to overcome and change structural racism and other structural inequities. Today, I want to explore how we as individuals can fight racism and health inequities every day and protect our patients as they navigate a healthcare system that inherently has structural inequities like racism built in. Interpersonal racism is a form of racism that is experienced between members of the dominant social group and members of a stigmatized racial minority. They are interactions occurring between individuals that often take place in the form of harassing, racial slurs, or telling of racial jokes, or more commonly in the healthcare system, in the form of microaggressions towards, prejudice against, or judgments about patients and families. It can be either explicit or implicit. Anti-racism is the work of actively opposing racism by advocating for changes in political, economic, and social life. Being anti-racist is to actively make conscious choices in our daily lives to identify and end racial inequities. No individual is free from internalized racism, and subsequently, every decision and action one makes is vulnerable to subconscious racial bias. This quote from Ijeoma Oluo, author of So You Want to Talk About Race, is particularly helpful in understanding the value of anti-racism. The beauty of anti-racism is that you don't have to pretend to be free of racism to be an anti-racist. Anti-racism is the commitment to fight racism wherever you find it, including in yourself, and it's the only way forward. Disparities are differences in outcome. Inequity is a difference in outcome rooted in injustice, which recognizes that even if we were to achieve equality, that is, everyone having access to the same resources, we would not achieve equal outcomes. Equity requires access to different resources based on need, which will allow everyone to achieve the same outcome. When we accept that racism is a fundamental cause of health inequities, we realize that we as members of a healthcare system must talk about racism and strive to achieve health equity. We must also recognize, as I mentioned before, that many other factors drive bias and lead to inequities as well, including but not limited to gender, sexuality, religion, ability, and disability. We've thus far reviewed the emergence and persistence of racism in our country and discussed why this is important in our field of pediatrics. Now we will explore a few more technical terms and concepts used frequently in health equity work. Bias, in general, is defined as prejudice in favor of or against one thing, person, or group. Biases start to form in early infancy. Explicit biases, on the left, are sets of conscious beliefs that you would be able to report about yourself. That is, you are aware of these biases. Implicit biases, on the right, are unconscious, automatic, and are generally not recognized or acknowledged by the individual. Explicit and implicit biases are natural and universal. We are constantly inundated with messaging through the media, from our upbringings, and the people around us. And this messaging forms bias that enormously impacts how we interact with the world. Both implicit and explicit bias play a part in racism. Bias comes into play when we make decisions. The dual process theory suggests that we have two components of decision-making. System one is the mind's fast, unconscious, intuitive approach, which can be good for lots of everyday decisions, but can be prone to errors. System two is the slower analytical mode and is more reliable. For example, let's think back to the classic one-liners doctors learned for exams. A 3-year-old with a history of asthma presenting to urgent care with wheezing will quickly lead to a diagnosis of asthma. The vast majority of time, this kind of pattern recognition and quick thinking will lead you to the correct answer. However, system 2 thinking is the slower mode and it helps you keep the list of possible diagnoses open. So in this example, perhaps this 3-year-old had an aspiration event that was missing. Implicit biases that contribute to health inequities are more likely to weigh in when we use our error-prone System 1 thinking instead of our more reliable System 2 thinking. As healthcare workers, we have high cognitive demands in our jobs with clinical uncertainty, large workloads, and fatigue. This makes us vulnerable to relying on System 1 thinking, and therefore often acting on our implicit biases, which have been influenced all our lives by racist messaging and societal constructs. We started our conversation with how racism impacts the care of children. We discussed medication misuse, inappropriate diagnosis, and inadequate pain management as a result of implicit bias. And we discussed the theory behind why implicit bias negatively influences our words and actions. Rather than intellectualizing this further, let's move from the abstract into the concrete and apply what we've learned to identify implicit bias and structural racism in the clinical scenarios. Imagine that you are an admitting provider called in from an outside hospital looking to transfer a patient, a 2-month-old full-term infant who is BIPOC and has a maternal history of drug use and in utero substance exposure, who presents with faltering growth. First, we would like you to reflect to yourself. What biased thoughts about this mother and patient come to mind? What concerns do you have for this baby or about this family? What might be causing this baby's poor growth? Please share in the chat.
Great. So we're seeing some comments about mother potentially using drugs, poor access to feeding and support, bias adversely impacting the child welfare, and access to food for mom and baby. And bad mother is another one. Postpartum depression.
Thank you for sharing. In the end, this baby had pyloric stenosis, an overgrowth of the muscular ring at the end of the stomach, which meant that his food could not pass through to his intestines. This condition classically presents with vomiting and faltering growth, and this baby's illness was entirely explained by this purely medical problem. There was no evidence of neglect and no sign that this mother was not fit to take care of him. Another concrete example of how bias influences our thinking. When this case was presented to a large group of physicians, nurses, pharmacists, and other healthcare workers, the offered explanations for this poor baby's growth range from neglect to incorrect feeding techniques, to incorrect mixing of formula, to wondering whether the family faced food insecurity or if the mother required social supports. No one offered a purely medical diagnosis, such as pyloric stenosis. Throughout this baby's hospitalization, the maternal history of substance use was repeated at each sign out as a part of the baby's identifying statement. Given what we know about fast thinking and implicit bias and racism, be on the lookout for places where you see this framing impacting how the family was treated. As we go through this case, put yourself in this mother's position. How do you feel, and what events led to those feelings? Let's delve further into the timeline of this case to see specifically where implicit bias had a role. The baby was sent from the outside hospital with the identifying statement we discussed. When he first arrived in the ED, from the medical standpoint, he had labs drawn but did not have an ultrasound ordered. From the social side, due to vague wording in a protocol, both social work and the hospital's child abuse team were consulted. Upon hearing the case, the child abuse team was not concerned for abuse and recommended standard social work evaluation upon admission. The next morning, the baby had projectile vomiting with feeds. At this point, an ultrasound was ordered. At the same time, from a social perspective, a CPS worker arrived on the floor. Although the medical team did not know this, CPS had been contacted by the outside hospital. The bedside nurse for this family was able to delay CPS meeting the family until they had spoken with the medical team. Pause and reflect. What biases may have led the outside hospital to call CPS even without a formal diagnosis? Please share in the chat.
So we have topics of history of substance use from mother, race, the idea of neglect as a function of poor weight gain.
Thank you all for sharing. After the ultrasound was completed and showed the pyloric stenosis, the baby was transferred to the general surgery service in anticipation of surgery. CPS also met with the family, having first been debriefed by the medical team. Unfortunately, that afternoon, the baby stopped breathing suddenly and had to be transferred to the pediatric intensive care unit. Pause and reflect. How might this family feel about CPS being called by the outside hospital? Please share in the chat.
So we're seeing comments about defensiveness, mistrusting the consult, angry, scared, confused, humiliated, distrust.
Thank you all for sharing. The case continues. On the third hospital day, the baby went to the OR for a successful surgery and was transferred to the floor postoperatively. From a social perspective, social work was consulted again by the general surgery team, quote, due to maternal substance use. Social work spoke with the family again, found no concerns, and advised no need for further CPS referrals. On the fourth hospital day, the baby transferred back to the general medicine service. In the same morning, a bedside nurse called social work because of concern that mom fell asleep with baby in her arms. A different social worker came and spoke with the family. Later that evening, a different bedside nurse called social work to report that mom left the baby's bed rail down when she went to the bathroom. A fourth social worker came to speak with the family. Pause and reflect. What examples of bias do you see?
This afternoon on All Things Considered from NPR.
We see mom being labeled by the hospital staff. Labeling as irresponsible, stereotyping the mom.
Thank you all for sharing. On the fifth hospital day, the medical team declined any further social work needs, documented that they had no concerns about mother's caregiving, and discharged the baby home with his mom. When I reflect on this case, there are a few places that seem to be influenced by bias, such as the immediate involvement of the child abuse team despite no active substance use and the delay in diagnosis of the baby's medical problem. We also noted that social work was consulted frequently for sometimes unclear, inactive, or very minor reasons. I want to highlight the source of this bias. We know that there is a long history of bias against families and mothers who use substances, despite evidence that these children and families can achieve equal outcomes when provided equitable social supports. As a result of this experience, this family will have the additional permanent and lifelong burden and stigma of CPS involvement, which will likely lead to further bias and health inequities in the future. Now that we have practiced identifying implicit bias and racism in a clinical case, let's dive into some tools that might be helpful to avoid similar issues in the future and prevent implicit bias and racism from harming our patients. In every patient encounter, and especially in patient encounters which we might find personally challenging, we should stop and walk through the following steps. Reframe the encounter. Instead of asking, why is this patient or family making these choices? We can ask ourselves, what needs are unmet and what biases we are bringing. For example, rather than thinking of this patient's mother as a mother who chose to use substances during her pregnancy and has a child who is not growing appropriately, think of her as a mother who is concerned about her child's growth and decided to appropriately bring him in for evaluation. Secondly, we can help each other in our teams by having open conversations and reminding each other of our biases. We can identify the biases we bring to the team and consider whether we are perpetuating or amplifying biases from other members of our team. For example, when a coworker tells us this baby has a mother with a history of substance use, ask, is this historical fact worth repeating? Is the stigma of this label worth perpetuating? Is it related to the baby's current problem? Finally, we can utilize systems resources and continue to prioritize training to help our teams better partner with families. For example, we can ask, is a second or third or fourth social work consult really necessary, especially since we now have a purely medical diagnosis and since social work has already met with the family and offered support? Self-reflection and critical thinking are important. Recognize your and others' biases. We can ask ourselves, if this family were a different race, a different ethnicity, or a different socioeconomic status, would I still call this consult? Challenge yours and others' biases. Ask, am I helping or hurting in addressing institutional and systemic harms? Practice taking others' perspectives. Think what it would be like to have your skills, abilities, and leadership potential filtered through the expectancy bias of negative stereotypes. Ask, how would I feel if I were in this family situation? What am I hoping for? What is the family hoping for? An area in which structural racism may be at play is when institutional resources such as social work and CPS are called. Social workers are amazing resources, both in our hospitals and outpatient clinics, who are primarily a source of support for families. Their role can include assisting in navigating the medical system, providing anticipatory guidance, helping families build self-advocacy skills, connecting families with community or institutional resources, mitigating the stress of long hospitalizations or complex medical problems, and helping families process the emotional burden of illness. However, this family had multiple social work consults placed in rapid succession. This may have been perceived by the family as biased or punitive. Even when we're consulting social work for equitable reasons, there are still sometimes barriers to the ideal way we would like to promote relationships. Sometimes we worry that having a difficult conversation might ruin our relationship with a family. But having that conversation yourself, rather than calling in social work as a mediator, helps build a shared understanding with the healthcare team, instead of setting up the social worker as the person who brings the bad news or conflicts. It also limits the perception that people are discussing issues behind a family's back with new people. One of the biggest barriers is time. We often worry that we don't have the time to have an in-depth conversation with a family, especially in the outpatient setting. But because we know these conversations are important, we may place a social work consult in an attempt to make that conversation happen. However, in reality, taking that 15 minutes now will actually save time later, because those conversations build trust with a family. It's also okay to begin a conversation with a family and empathize, then offer to come back later and talk more. Every opportunity to build trust with the healthcare system is valuable. Sometimes we are hesitant to start conversations with families, especially if we don't know what resources exist to help. But when social work is consulted without the provider explaining or exploring with the family first, it can create a conflict with the family who may feel in trouble because a third party was brought in. So to be transparent with families and normalize social work consults, for example, say something like, hospitalizations are stressful even in the best of circumstances. How would you feel about social work coming to talk about how you're doing, how your child is doing, and if there are things we can help you with? This also alleviates parents' worries about the role of a social worker and the assumption many families have that social workers have to do with CPS and removal of children. It sets the social worker up for success by setting a goal for the meeting and letting parents prepare to talk with someone. Emphasize that social work involvement is optional. This empowers families. And if a family declines, it's important to document this so that decision is respected and social work is not offered over and over as it was in this case. Even if you work in an environment that does not have direct access to social work, these are still valuable strategies to provide equitable care and support for families. We know that words matter. In this case, this baby was identified as having a mom with substance use disorder every time he was signed out. But we know that repeated exposure to stigmatizing language, such as derogatory terms of addicts or abusers, rather than person-first language, changes healthcare providers' attitudes and clinical decision-making. Conversely, we know that integrating a person's life story into their clinical documentation and sign-out actually reduces stigma. For this family, we could have referred to this baby simply as a 2-month-old with faltering growth because mom's substance use wasn't relevant to his current problems. Alternatively, we could have included more social information in the sign out or documentation rather than just reducing it to, quote, a history of substance use. Imagine that another provider is giving you a handoff or summary about a patient you'll be taking care of. If that provider casually describes the patient with stigmatizing language, you will be primed to believe certain assumptions about that patient and family before you even meet them. So changing and destigmatizing the language of a handoff is a critical tool you can use to interrupt that interpersonal bias from being carried forward from handoff to handoff and influencing every healthcare worker along the way. How do you respond in the moment when you feel that a coworker, friend, or loved one is exhibiting bias, either conscious or unconscious? Take a second to pause. Sometimes silence can accomplish far more than words will. Approach from a place of curiosity. Don't make assumptions about anyone's intent. Ask the person, why do you say that? This is a wonderful open-ended question which really allows the other person to reconsider and reflect on their words or actions. If bias or judgment is central to their words and actions, it will become clear. Use empathy to reframe the situation. For example, saying, wow, that family has had a difficult time accessing the resources they need. Name the offense. For example, I would like to avoid unnecessarily calling security on this family of color. Support the target of the bias, saying something like, this parent is doing a wonderful job advocating for their child. You also do not have to speak up in the moment. In fact, in the moment feedback may not always be appropriate. Please feel empowered to talk privately with your coworker after an incident. We can all complete diversity training and read about anti-racism and still not feel comfortable affecting change in our workplaces. The only way to address inequity in medicine is to practice interrupting racism and bias every day. So let's take this time to practice these skills in a few brief clinical scenarios. Imagine you are working in the newborn nursery. A 23-year-old mother who identifies as BIPOC with a history of substance use disorder, now on Suboxone, delivers a full-term infant via vaginal delivery. Both mother and infant are well. Later that evening, she asks when she will be allowed to leave the hospital. After hearing the history of substance use, the overnight nurse, who identifies as white, feels that the mother's question may be a sign that she might leave with her infant prior to medical clearance. Without the mother's knowledge, she calls CPS overnight, leaves an urgent message for social work, and requests an administrative hold, which would allow separation of the mother and infant. If you could have stepped in, which of the following tools would you use and how? Please share in the chat.
So we're seeing team dynamics, reframing the encounter, and 3, 4, 5, and 6.
Perfect. Thank you all for sharing. In this scenario, no coworker stepped in to question why the overnight nurse was taking so many immediate and major actions against this mother. The next day, social work investigates further and finds that the mother had no intention of leaving by herself or with her baby without medical clearance. She'd only been asking for this information because she delivered her first child via C-section and had been told that she could be discharged sooner this time. CPS also arrives, evaluates the family, and agrees with social work. In this case, institutional resources and training were used to support the family, although they were not brought into the situation equitably. Social work took the time to understand the situation fully and debrief the medical team. They helped team members understand how communication was imperative and that an urgent social work consult and CPS referral were not necessary in this case. In this case, the sources of bias against this family are likely the history of substance use and the mother's identity as BIPOC. Now I want you to imagine that you are working in the emergency department. A 17-year-old patient with cancer who identifies as BIPOC presents to the emergency department 2 days after her last chemotherapy cycle with severe nausea and vomiting. She is ill appearing and very thin and lying in bed, not making eye contact. She doesn't want to speak to you, so her mother answers all of your questions. The patient does allow you to examine her. She continues to vomit and feel nauseous, even when given oral anti-nausea medication. She refuses to take her birth control pill, but does take her anti-seizure medication. Her nurse comes to you and asks, "So what's the plan? I feel like she doesn't want to participate or accept the care that we're offering her. If she doesn't want to be here, I think we should send her home." Pause and reflect. Do you think there is bias in this response? How do you respond in the moment? Which of the following tools would you use and how? Please share in the chat.
Shriti, can you go back to one slide so they can see the case? There you go. So we're seeing comments about reframing, providing education, challenging assumptions. Quite a bit of reframing here, Shriti.
Wonderful. Thank you all for sharing. This patient identifies as BIPOC. Let's recognize the bias. We know that Black families in particular are more often characterized as non-compliant, uncooperative, or even angry compared to white families. We can reframe the situation. It seems reasonable that a teenage patient who has cancer and is experiencing nausea and vomiting after chemotherapy may not want to speak too much or take a medication that's not immediately medically necessary, such as birth control. And she had been cooperative and engaged with the medical team when she allowed a physical exam and took both the anti-nausea medication and the anti-seizure medication, which were immediately medically necessary. Here's an example of what might happen if you try to address this in the implicit bias in the moment. The provider pauses for a long time, continuing to make eye contact and staying engaged with her coworker. The coworker becomes visibly uncomfortable, and the provider asks with genuine curiosity, "Why do you say that?" The coworker pauses for a long time and finally says, "Well, I just feel like she doesn't want to be here if she doesn't want to take the medications we're giving her." The provider does not respond immediately, so the nurse qualifies her statement and continues. But I guess she is in a lot of pain and really nauseous, so I guess that's reasonable. The provider agrees and says, absolutely, I agree. She's in quite a bit of pain and feeling really terrible right now. She's been in and out of the hospital so much for her cancer, and I'm sure she really doesn't want to be in the hospital again. Her birth control pills are not immediately necessary for her to take, but I'm glad she took the anti-seizure medication. It seems that we haven't really made her feel better yet, so let's see what else we can try. In this case, after multiple doses of oral anti-nausea medications, the patient was given 2 boluses of IV fluids in the emergency department, but her nausea and vomiting continued, requiring a 2-day hospital admission for IV fluids and IV anti-nausea medications. If we had discharged this patient because she was, quote, uncompliant or, quote, unwilling to participate, we would have caused harm to this patient. In this case, the sources of bias are likely her intersecting identities as BIPOC, an adolescent, and female. Thank you all for participating and walking through these cases with me. I hope you find this exercise and these tools useful to you in your daily practice. As we conclude our session, these are the points I'd like to emphasize. Know when you're most susceptible to relying on implicit biases and System 1 thinking. Knowing that you are more likely to be influenced by implicit bias when you are tired or busy will help you stop and reflect on your decisions. The words we use in our handoffs and patient notes are going to be read by other providers and shape perspectives in lasting ways. Use them to interrupt racism. Reframe the situation. Instead of asking, what is wrong with that parent? Ask, what has happened to that family and how can we support them? With perspective taking, we have the opportunity to support families going through challenging times by recognizing their strengths and the impact of our behaviors. Challenge your own and others' biases. Speaking up when we see inequity matters. Each of us carries racial bias, and each of us will make mistakes along this journey. But with awareness, motivation, and deliberate practice, we can strive to address and prevent health inequities in each of our practices. Thank you all for joining me and allowing me to share with you today. I'd like to thank the Washington chapter of the AAP for giving me this opportunity. I'd like to thank my faculty advisor, Dr. Roberto Montenegro, for his advice and support. I'd also like to thank Dr. Tracy Seamers, my Health Equity Rounds advisor, and my whole Seattle Children's Health Equity Rounds team for inspiring me to think about health equity every day.
Thank you so much, Sriti, and thank you, everyone. I'm very impressed that there are so many people that logged in and are awake this early in the morning. And I guess I have to remind myself, y'all are hardworking pediatricians, so you're used to being awake this early, and thanks for joining us. I also want to really thank Sriti and her amazing dedication to this topic and the fact that she was able to put this entire talk together while she was on the NICU, many long hours. And I think your great job is definitely evident in today's presentation. So I'd like to open it up to questions, and I think we'll be getting a little bit of help just reviewing some of your awesome questions. But I took some notes, Sriti, with some comments that were being made or asked while you were speaking. And some of the general themes that I think became apparent is people recognizing that they do feel that words are priming them for potential bias, especially when they log into Epic, for example, and they review the patient problem list, and that already starts impacting their differential. So again, understanding the impact of words and bias. And also some people were giving great recommendations on potentially doing warm handoffs with social work. And you were using social work as a very clear example, something that you have seen yourself a lot in the cases that you presented, which were your cases and some of your colleagues' cases. And something important also that was brought up is, and to clarify that, we were definitely not insinuating that this is all nurse driven, right? And that, like someone mentioned in the chat, everyone plays a role. I think one thing to keep in mind is that in some of the work I've been doing, a lot of trainees feel that they don't have the power to speak up, especially with senior nurses or nursing. So it's really hard for them to push back when they feel that an unnecessary or there's an inappropriate consult, which is, I think, a great point for all of us as attendings to keep reminding ourselves that we should continuously empower our trainees and let them know, hey, we have your back. If you think something's inappropriate, we have your back. And if they make a call that ultimately ends up leading to tension, you'll be there to help them process it. And that way you start modeling advocacy early on. Luckily, we have people like Sriti, who's an intern and is already very skilled in advocacy and the lens. And now she's teaching us and reminding us how to reciprocate that, right? So I think, thank you for that comment on the chat. And also with continuity of care, Sriti, like you were suggesting also, trying to have social work be on the same team as their patient is transferred would be helpful. And also recognizing, like someone put in the comments, that it's not only nurses or physicians that have biases, and it doesn't matter what degree you have, we all carry biases. And simply because we all carry biases, it doesn't make it okay, right? Our goal and thought here is that we constantly challenge our biases so that we can begin to challenge other people's biases as well, in a way that leads to learning and genuine curiosity and collegiality. So those were some of the themes, Sriti, that were coming up while you were speaking. Let's see if we can turn to the chat box and see if there are any other questions. So any questions? Feel free to unmute yourself as well. Yes, there's a question about the efficacy of training for bias reduction, which is a great question. There is and if there are any studies, and Anthony, thank you. You put some links there to some articles that look at efficacy of training. There's another one that is being done nationally. It's a first randomized control trial for bias reduction in medicine specifically. And UW is one of the sites that is participating in this NIH randomized control trial called BRIM. And so I'll put the link there for anyone that's interested in this study. I'm one of the co-leads in this initiative, and we're actually modifying and implementing this study for pediatrics at Seattle Children's Hospital as well. Sriti, do you see anything else that you'd like to address?
Oh, I just wanted to comment on a couple things. One was that we are all in learning. And so there was a comment about sort of the discussion about outside hospital and how we talk about outside hospitals. And instead of it being outside hospital, it being referring hospital for the case, which I think, I mean, that is before even I as a resident, like used to say outside hospital, and now I work at an outside hospital. So I do think that it is really important that we think about the ways in which we also talk about our fellow colleagues. But again, we are all learning, so I really appreciated that. And then also thinking about sort of how we talk about our patients that have a history of substance use, instead of just saying a history of substance use or IV drug use, saying that they are in recovery, because certainly the patient in your example, Shruti, was in recovery, and making that sort of from a strengths-based perspective as opposed to the fact stigmatizing their history of diagnoses.
Thank you.
I love all of those suggestions, and yeah, an example of growth for myself that we're all learning, and I learned so much from those comments. So thank you so much for those who shared that.
Sriti, and Roberto, I'm not sure if you looked at the chat. Dr. Jackson, Craig Jackson just put a note in there, and I think that it's relevant because it kind of speaks to one of the points about, you know, as clinicians, we're always trying to create a differential diagnosis, and we use our tools to do that. And how do we kind of separate our implicit bias from those tools when we're rapidly trying to treat someone? Are you guys able to comment on that?
Yes, I could comment. And then I see Eric, you're using the hand function. Awesome. I can comment on that, but maybe open it up to Eric. Is it related to that question, or would you like me to
It's
address?
separate, so I can wait.
Separate. Okay, great. So yes, in the actual BRIM study and I put the link there, we do look at system 1 and system 2 thinking. And we look at neurocognitive science and social psychology science that helps us decrease the biases when we're in system 1, system 2. So there are some strategies that we just couldn't go into because of the lack of time, but definitely there's one in particular with individuation, for example, that helps reduce bias from system 1, which helps us, but also recognizing bias in the literature, right? So for example, in my field, I know that there's system 1, I'm doing an evaluation, I'm thinking ADHD, and then I also know that the literature shows that young Black girls are often misdiagnosed and undertreated with stimulants. So I use that information to counter my systems 1 thinking and make sure that it's checking me. So being familiar with the literature and using it to counter your system 1 thinking is important. Eric.
First of all, I'm so grateful for this conversation, and I wish I could actually be training in this era where we're more aware of these biases and in programs like which you guys are developing. So thank you very much. I'm kind of aware that I've become aware that these conversations about diversity and equity are also occurring in kind of a cultural landscape of popular home DNA kits, Ancestry.com, even like the TV show by Henry Louis Gates Jr. about, finding your roots. Are these conflicting?
Are these conflicting?
Yeah, conflicting with our concepts of race and the biases that grow from that.
That is a great question, Eric. It's been a while since I've gotten that question, so thank you. It's conflicting and challenging especially the fields of race relations and sociology, for example, where we have geneticists who are finding genetic markers, but they're using them as geographical sort of placeholders, if you will. And so it is conflicting where we're saying race is a social and political construct, but now they're finding that genetically you can find markers of historical ancestry. But that conflation of race with ancestry is still problematic because we're assuming that because there's what we made up as race and now there's a geographic location that then that dictates phenotypes or outcomes that are specific to this geography. But like Sriti said at the very beginning, when you look at the geographic or the genetic distribution and representation, even within a region, you see more variation in genetic makeup. So once you understand that just because it can locate you to a geography, but when you look at the genetics in that geography, there's so much variation, it really doesn't help out. Understanding those genetic, the race markers, sorry.
Right, and I think that that's not being, messaged.
It's
right?
not. Mm-hmm.
Yeah.
Yeah.
Well,
thank you for pointing that out. Yeah.
I think we have time for one last question, and I actually did want to highlight this question because it came from one of our providers. I think the question was really about sort of reinforcing what are some good ways to address and bring up issues when you are concerned that bias is leading to inequity in care. And I know, Shruti, you already talked about this, but just sort of to bring a final point to that. And then also even to expand the question within institutions and not just amongst colleagues, but when you notice that there might be a policy that is disenfranchising our patients.
Okay. Great. So, sorry, that was my timer to make sure we weren't going over time. Great question, complicated. I really think that the toolkit actually provides some references to some great journal articles that talks a little bit on how to empower or gain more knowledge in being able to identify, right? And the toolkit also talks about structural racism and anti-racism. I think reviewing the toolkit will be a first good step in getting skills on how to name it. And we talked a little bit of those, but it just requires a lot more learning and practicing. You will make mistakes when you're trying to address racism, either interpersonally or institutionally and systemic wise. But you just have to keep going and working on it. So it's a complicated question, but there are resources out there. And once the toolkit becomes available, I think you'll find great references there that can point you there. You can also always reach out to us. And I know Seattle Children's Center for Diversity and Health Equity has a great resource list as well of tools on how to do just what this question was asking.
This is Michael Aronson, one of the residents, and something that someone told me once is to start those sentences with "I feel." So if the nurse in this situation was, "I feel like we should send this patient home," and then someone can say, "Well, I feel like, you know, maybe there are things under the surface here that we're not currently paying attention to." That really seems to help me at times.
Yes, thank you, Michael. That's partly part of the communication strategies that we train the residents at Seattle Children's, is using some DBT, dialectical behavior therapy strategies, which does recommend, Michael, like you're saying, to start difficult conversations by explaining the emotions behind your statement, or your feelings, I should say, behind a statement. So thanks, Michael.
All right, and it is 8:01, and Kathleen and I do not like wasting your time. So we just wanted to thank Dr. Montenegro and Dr. Prashardi for doing an incredible job with bringing all this information to us. And I really am speechless, so thank you so much. This was a really, really incredible. And we are so excited for some of the work that you guys are doing and for teaching us. I did not plant Roberto, but yes, the toolkit is going to be available, and a lot of the information and questions that people are asking about are inside of the toolkit, and that will be available next week. I also wanted to let people know that the next webinar is going to be June 30th at 7 a.m. And I cannot believe that so many of you woke up this early. I know that I can't believe it. And then the last thing I also wanted to say was, you know, this work takes practice. And when we practice and we continue practicing, it becomes a social norm. And so the more that we are willing to be vulnerable and courageous and practice with ourselves and our colleagues, the easier it will become. And so I hope people do that from a space of compassion, but also bravery. And finally, again, I just want to thank our speakers and also thank all the work that everybody statewide is doing to support our patients and families. And with that, we'll let you go. Kathleen, did I miss anything?
No, thank you all for coming and bringing yourselves and participating, and special thanks to our speakers. You were amazing. Thank you so much.
Have a wonderful morning, guys.
Thank you.
Thank you, everyone.